Our next presenter is Dr. Randa Ahmed Elgarhy. Dr. Randa is a teaching assistant at pathology teaching assistant at Faculty of Medicine, Ain Shams University, and she will be presenting a presentation entitled The Crescendo under supervision of Professor Dr. Reham Ibrahim, Assistant Professor of Pathology at Faculty of Medicine, Ain Shams University. Dr. Randa, can you hear us?
Yes, Dr. Muhammad, can you hear me?
I can hear you now, and I can see your screen. You may start slideshow and go on.
Okay, thank you. Good afternoon, everyone, my dear professors and my dear colleagues. I am Randa Elgarhy, a teaching assistant of Pathology Department at Ain Shams University. I would like to thank Shefa Al-Orman Hospital for organizing this event, and I would like to thank Dr. Reham for giving me the opportunity to discuss this case under the title of Crescendo, musical term which means a gradual increase in loudness. So, let's start. A 6-year-old male child presented to Ain Shams University Hospital with left axillary swelling and weakness of left hand grip. Few cutaneous dark patches were noted. Later on, the patient developed quadriparesis of subacute onset and progressive course. MRI cervical spine was done, revealing C6 and 7 extraaxial intradural space-occupying lesion. An excisional biopsy from the lesion was done, and it revealed multiple fragments of hypocellular and hypercellular areas, which later on revealed they have different grades. The low-grade fragment showed a low power of a hypocellular spindle cell proliferation, while the high-grade fragments revealed a hypercellular spindle cell neoplasm with herringbone pattern and fascicular arrangement. On higher magnification, the low-grade fragment showed ablant cytological features in a myxoid background with mast cells and shredded collagen, while the higher fragments revealed a high degree of atypia, hyperchromasia, prominent nucleoli, mitotic activity reaching up to 25/10 high power field. Areas of necrosis were also seen. So, with this clinical context, radiological background, and the special histological features of this lesion, we were guided towards a neural origin, and we decided to start with a limited panel of immunohistochemical staining. SOX10 and S100 were patchy positive in the low-grade fragments, with reduced expression in the high-grade fragments, confirming the neural origin of the lesion. The next panel was done to assess the specific tumor classification and grade. CD34 revealed intact lattice-like or finger-like positivity in the background of fibroblastic meshwork in the low-grade fragments, while it was lost in the high-grade fragments. 67 was low in the low-grade fragments and revealed a high proliferation index in the high-grade fragments. H3K27ME was retained in the low-grade fragments, while it was lost in the high-grade fragments with positive control. Desmin was also done and was completely negative, excluding any rhabdomyoplastic differentiation. So we were in front of a crescendo pattern in this lesion, and now lots of you knew the diagnosis. It's a neurofibroma transforming to malignant peripheral nerve sheath tumor, high-grade neurofibromatosis associated. Our child was diagnosed as neurofibromatosis type 1 as he has fulfilled its criteria. It's also called von Reckling-Hussel disease. It's autosomal dominant syndrome, 50% sporadic cases with mutations in neurofibromin gene. 2 or more criteria has to be seen. 6 or more cape-ole patches, 2 or more neurofibromas, 1 or more plexiform neurofibroma, prickling in axilla and groin, optic nerve glioma, 2 or more Lesch nodules, distinctive bony lesion. This is the WHO classification of the soft tissue tumors, showing proposed nomenclature for the spectrum of neurofibromatosis type 1 associated nerve sheath tumors, including neurofibroma, plexiform neurofibroma, neurofibroma with atipia, cellular neurofibroma, atypical neurofibromatous neoplasm of uncertain biologic potential, low-grade and high-grade malignant peripheral nerve sheath tumors. So there is a kind of crescending transition in this spectrum, from neurofibroma up to atypical neurofibromatous neoplasm of uncertain biological potential, up to malignant peripheral nerve sheath tumor. Neurofibroma is a benign nerve sheath tumor composed of mixture of Schwann cells, perineural-like cells, fibroblastic cells, mast cells in a myxoid background. Neurofibromatosis type 1 association is frequent in visceral, multiple cutaneous, and massive soft tissue neurofibromas, while neurofibromatosis type 2 association is rare and it occurs in cutaneous neurofibroma. 5 macroscopic forms of neurofibroma are distinguished: localized cutaneous, diffuse cutaneous, localized intraneural, plexiform intraneural, and massive diffuse soft tissue tumor. The plexiform neurofibroma is a multinodular subtype with involvement of multiple nerve fascicles. It most often involves large nerve or plexus, imparting a bag of worms. It's highly associated with neurofibromatosis type 1 with an increased risk of transformation to malignant peripheral nerve sheath tumor. Cellular neurofibroma accounts for hypercellularity in the absence of other worrisome features. They lack the uniform cytological atypia, chromatin morphology, and mitotic activity seen in malignant peripheral nerve sheath tumor. Neurofibroma with atypia or ancient neurofibroma, characterized by scattered atypical or bizarre nuclei and smudged chromatin in the absence of other worrisome features. It's not considered a pre-malignant lesion. Coming to the atypical neurofibromatous neoplasm of uncertain biological potential. Perhaps our case had areas that can fulfill the criteria of atypical neurofibroblastic neoplasm, but because we had two ends of the spectrum merging together, these areas could not be accurately highlighted. At least two of these features has to be present: cytological atypia, loss of neurofibroma architecture either on H&E and/or CD34 immunostaining, hypercellularity, mitosis more than 1 per 50 high power field and less than 3 per 10 high power field. On neuroimaging, it can be suspected when there is a distinct growing nodule and/or increased PET activity, strongly associated with deletions of the cyclin D kinase, the cyclin-dependent kinase inhibitor 2A or 2P. Coming up to the malignant peripheral nerve sheath tumor, it's a malignant spindle cell neoplasm arising from peripheral nerve from a pre-existing nerve sheath tumor or in patients with neurofibromatosis 1 or in the setting of previous radiation therapy. It's rare in pediatrics. The low grade has features of atypical neurofibromatous neoplasm of uncertain biological potential, but with mitotic index of 3 to 9 per 10 high power field and no necrosis, while the high grade had at least 10 mitosis per 10 high power field or 3 to 9 mitosis per 10 high power field combined with necrosis. As stated by Dr. Muhammad Hussein today, epithelioid malignant peripheral nerve sheath tumors show diffuse S100 and SOX10 positivity, and it has loss of SMARCB1 expression. Malignant Triton tumor is a malignant peripheral nerve sheath tumor with skeletal muscle differentiation. The molecular of the malignant peripheral nerve sheath tumors includes mutation in 3 pathways: neurofibromin 1, cyclin-dependent kinase inhibitor 2 and B, and PRC2 core component with a mutation in the H3K27ME3. The prognosis is poor with some adverse prognostic factors as truncal location, tumor size more than 5 cm, local recurrence, and high-grade morphology. patients with neurofibromatosis-associated malignant peripheral nerve sheath tumor appear to have worse prognosis than sporadic cases. So, if this case was purely high-grade without pre-existing low-grade lesion, differential diagnosis would be wider, including pediatric spindle cell sarcoma, including spindle cell rhabdomyosarcoma, monophasic synovial sarcoma, malignant peripheral nerve sheath tumor, infantile fibrosarcoma, low-grade fibromyxoid sarcoma, and undifferentiated sarcoma. Correlation with clinical, radiological, and histopathological immunohistochemical data will help to reveal the diagnosis. So our take-home message is that always think of malignant peripheral nerve sheath tumor when encountering cellular spindle cell neoplasms in patients with neurofibromatosis 1. Sudden enlargement or pain in large neurofibromatosis 1 associated neurofibroma is always alarming clinical sign. And it's important to sample large and plexiform neurofibromas since malignant change may be focal and difficult to recognize. Our child has started treatment but developed lung metastasis, and unfortunately we lost him, and he became an angel due to this crescending lesion. Thank you all for your listening.